But before we get started in the nitty-gritty with regards to the budget and her mandate letter, I'd like to address something that she actually just mentioned a couple of times during her remarks, and had also mentioned during the question period that we had that was devoted one full day on the opioid crisis. And it's the term 16 years of neglect. I know the minister has been very clear about this topic, and she said it numerous times that this topic is a non-partisan topic and shouldn't be political, but by using the term 16 years of neglect, it's totally politicized. So I want to ask the minister, as we move forward, when you say 16 years of neglect, are you suggesting that the government for 16 years, the BC Liberal government, did nothing for mental health and addictions?
Minister of Mental Health and Addictions.
Thank you, Chair. I'd like to make a distinction, and it's one that I have made before. I think the member has heard me make this distinction, but I will repeat it. I have never criticized Minister Terry Lake for his response or the government's response to the overdose crisis. And when I've spoken in the legislature, I've said very clearly that the overdose crisis is not a partisan issue, that I've not treated it that way, and that I was hopeful that members of the opposition would not treat it that way. What I think is a matter of fact is that our system for mental health and addictions care has been under-resourced, is fragmented, is uncoordinated, is not seamless, and there are huge gaps. And that's not just me saying that, it's not just our government saying that. This is what I'm hearing from every family member I speak with, every person who's come in contact with the system for mental health and addictions care. It's what I'm hearing from stakeholders across the province. So as I said in my opening remarks, there is some exceptional work that's happening out there, and there are an awful lot of very, very dedicated people who are pouring their hearts and souls into doing the best they possibly can within a system that is not coherent. And, you know, I don't have copies of the reports from the representative for children and youth in my hands, but I think we all remember as if it were yesterday the report that the current representative for children and youth released in October, Joshua's story, where he described in excruciating and painful detail the experience of Joshua and his family that spoke not to lack of professionalism, not to failures of individuals, but to system failure. He talked about how the education system got involved. They stepped in and then they stepped back. He talked about how the healthcare system stepped in and they stepped back. He talked about children and families stepping in and stepping back. But no one was responsible for Joshua's care at the end of the day. And he used that in order to really illustrate the same thing that I've said here today. And as we know, the representative is not a partisan appointment. It's a bipartisan appointment. He used it to underscore the need for a seamless and coordinated system for child and youth mental health. And his overarching recommendation coming out of that report was that our ministry, I was already given this mandate, but he really reinforced that we needed to develop a plan for child and youth mental health, a seamless and coordinated system for child and youth mental health where there isn't one now.
Member.
Thank you, Chair. And there still isn't one now. The point being is that this issue is extremely complicated. I've been involved in this issue for several years. Certainly the minister is aware of my involvement with the Select Standing Committee for Children and Youth and in my role as Parliamentary Secretary. But my point is that because this issue is so complicated and encompasses so many different ministries and so many different people living on, dealing with so many different levels, it is a complicated system. And certainly we all do agree that it is fragmented and that there are gaps and ministries don't talk to each other and all of this sorts of stuff. But my point is I wanted to get to the area here when we're doing estimates that we agree that there is no way that when we were in government that this issue was neglected. And if we can't come to an agreement of that, then I'll go through perhaps down a little bit of memory lane. The member mentioned Terry Lake, and I know that the minister had to apologize for a tweet that her party put out that insulted our government at the time with regards to ignoring the overdose crisis. She had to apologize to Terry Lake because of that. He appreciated the apology, but the fact is that these mantras are still coming up. So what I'd like to just reiterate for the record, that our health minister did win this National Public Health Hero Award, and I will quote the Canadian Public Health Association. The Honourable Dr. Terry Lake, former Minister of Health for British Columbia, has accomplished many things, but nothing with more impact on the lives of some of the most vulnerable people in our province than the unwavering support he provided for the declaration of the public health emergency and the subsequent actions to stem the tide of tragic deaths from illegal drug overdoses in British Columbia. And the minister at the time was responsible for the public health emergency that was declared, that offered considerable amount of resources that might not normally be available. But my point is that these things happened under the previous government, and many of the initiatives that this government is doing and initiating were actually started when we were in government. Is the system perfect? No, it's not perfect, and we recognize that. I certainly recognize that, but I think I really do take exception to the minister when she said, when we had that opioid day in question period, on the one hand that it was 16 years of neglect, and on the other hand taking credit for Foundry, for instance. And we all know that Foundry was started when we were in government. So you can't say 16 years of neglect on this hand and then on the next hand take credit of something that our government actually initiated and they're just following. So I wanted to put that on the record. Thank you, Mr. Chair, for allowing me to do so. And on that note, I just have one question that was not answered that I asked in question period that I am going to ask the minister again, and it gets to the point of how will we know we've done a good job, right? How will we measure whether or not there's been positive results with the new minister or with the actions that have been instigated by this new government. So the question is, will the minister establish performance measures that set the goal of reducing the overall death rate?
Minister.
Thank you, Honourable Chair. Absolutely, we want to save lives. Absolutely. All the people who are working on the front lines want to save lives. They are giving every fiber of their being every single day trying to do that. But there are some factors that are Canada-wide, North America-wide, and international in scope that we can influence, but that we don't get to control. And I'm talking about a poison drug supply. We know why people are dying today and the numbers that they're dying. It's because of a poison drug supply. And a new alert just went out in the last few days about another even more potent doses of carfentanil that are out there on the streets that are claiming sometimes several lives in a day. So as you know, our government has taken measures on different fronts, including an anti-trafficking task force, beefing up resources there, introducing pill press legislation, collaborating with other public safety and enforcement officials. But there's some pieces that we don't control. If it weren't for poison street drugs, we would have considerably fewer. I think an estimate I heard from the coroner was that 300 or 400 people would have died. That's still 300 or 400 people too many. But we know that the overwhelming majority of people who are dying because they're turning to street drugs, which are laced with poison, which is killing them. But I want to go back to the issue of lives saved, because there have been literally thousands of lives saved. And I know the member knows these, but perhaps has chosen to overlook them in asking the question. We have had 800,000 visits to overdose prevention sites and safe consumption sites. 800,000. the number of overdose prevention sites and safe consumption sites has been steadily increasing. At these sites, 5,300 people have had their overdoses reversed. That's just at those sites themselves. We also have out in circulation close to 90,000 take-home naloxone kits. Almost 20,000 naloxone kits have been used to reverse an overdose. That's lives saved. 20,000 overdoses have been reversed. We have drug checking that's in place at all of our overdose prevention and supervised consumption sites. And evidence shows that if people utilize the drug checking equipment, it does change their behavior. It might not mean that they don't use the drugs at all. Sometimes it means that. Other times it means they use less of it. That helps to save lives. We are, through our Overdose Emergency Response Center, we are working very, very hard to connect people, not just to save lives, but to connect them to treatment and recovery programs as soon as possible. So our Overdose Emergency Response Center and the teams and the health authorities and on the ground are doing some really, really admirable work. After someone's life is saved with naloxone, trying to have conversations with that person and then connecting them with treatment as soon as they possibly can. We are working with our first responders so that first responders, including police and fire and paramedics, will be in the future, some are already doing it, but in the future will be able to directly connect people with treatment, how they can access treatment, not having to go to an emergency room. So there is some really remarkable work that's happening out there that is saving lives and is connecting people to treatment as soon as we possibly can. And I'm very, very proud of the work that's been done to date.
Member.
At the overdose response centers, the minister mentioned access to treatment. What are the pathways if somebody comes to an overdose response center to get treatment?
Minister.
Thank you, Chair. If I could just ask the member to clarify. I think you said Overdose Response Center. So I'd just like to clarify, are you talking about the Overdose Emergency Response Center, the provincial one, or are you talking about overdose prevention sites, local ones? Provincial sites.
Member.
Overdose prevention sites.
Members
Okay.
Committee, could you direct comments through the chair, please? Thank you. Thank you.
Okay. Well, the overdose prevention sites then, there are several things that happen there that help people to get on a pathway to care. I think the first thing that I would mention is the importance of just the staff who work there, building that connection, building that relationship with the people who come in the door and who are using the site. And sometimes that begins with food, sometimes it begins with wound care, but it begins by establishing a relationship of trust. And it can then hopefully progress from there to a conversation about whether the person wants access to treatment and how they can do that. So there are resources at these overdose prevention sites that can help people get to the services that they need. They're certainly familiar with all of the services that are available to people, whether that is referring them to a clinic, whether that's referring them to a rapid access clinic in a hospital. There are a variety of places that they can refer people for treatment.
Member.
Thank you, Chair. So just on that line of questioning, what documentation does the ministry have that actually shows how many people are connected to treatment and where did they go? And if there's any record of the person coming back to the overdose sites, this is the overdose prevention and supervised consumption sites, and how many times they would come back to those sites. Does the ministry keep record of any of those?
Minister.
Thank you, Chair. Well, Honourable Speaker, I thought that the member would understand, but perhaps she doesn't, and I'll explain it to her, that the overdose prevention sites are, they don't keep records of people who come in the door. They don't keep names. These are safe places for people to come. There are no barriers for people to come in the door. As a ministry, we don't keep records of the names or the numbers of people who visit overdose prevention sites. It is absolutely critical to the success of overdose prevention sites. I mean, let me step back a minute. We all know how enormous stigma still is in our province and in our country, and in particular stigma about drug use, and in particular stigma that relates to use of illegal substances. So if people had to say who they were, give information when they go to an overdose prevention site, that would be a barrier to them coming there. It would be a barrier to the lives that have been saved. It would be a barrier in terms of saving lives. We have, in the province, expanded access to care and to treatment considerably. And I'm happy to share those overall figures so we don't have them site by site, but I can tell you that between June the 1st of 2017 and February 28th of 2018, so we could, extrapolate and add numbers to these, but going back to February 28th, we have had in that time period alone, we've had an 80% increase in the number of providers in British Columbia who are prescribing opioid substitution therapy, an 80% increase in a 9-month time period. And these figures precede the regulations being changed so that nurse practitioners can now prescribe opioid substitution therapy. So of approximately 450 nurse practitioners in the province of British Columbia, over 107 have commenced that training. Some of them have concluded the training. So these numbers are going to continue to go up. We've seen a 28% increase in that time period of people on opioid substitution therapy, and a 164% increase of new people on opioid substitution therapy. So we are moving forward, Honourable Chair, and we are connecting more people to treatment. I think these figures show that very clearly. And certainly this is making a difference. Far more lives would have been saved if we did not have many more people prescribing, if we did not have people being referred from overdose prevention sites and from other places to these to people who provide treatment. We have a lot of work still to do, but we're making some important progress.
Member.
So I'm just trying to reconcile, again, going back to my other question with regards to performance measures and how you measure success. Because I would assume that success is helping people get well. If the same person is coming over and over to the same overdose site and you're not taking records of them, how can that be measured as success if somebody's just coming in and out and in and out and in and out? And I know, talking to first responders, that sometimes they're reviving the same person even on the same day. So I really do want to get back to what is the definition in the minister's mind is success.
Minister.
Thank you, Honourable Chair. I want to go back to some of the comments I made a few minutes ago, because having 800,000 people visit safe consumption sites and overdose prevention sites is a measure of success. We have a public health emergency out there. 3 to 4 people a day are dying. Many more would die if they were not visiting overdose prevention sites or safe consumption sites. And I'm not sure what the member is saying. This model was actually established, and the member wants to be nonpartisan on the overdose crisis. This model was established with Terry Lake as minister. There were no requirements then, and there are no requirements now that people have to give their names, their health information, There are no barriers to care in these sites. Do people come back more than once? They do. Opioid addiction is a very complicated and very, very serious condition. Addiction in general is a chronic relapsing condition. We know that. We know that even if people enter treatment or have been in long-term recovery, that recovery is a lifelong journey. Addiction is a lifelong relapsing condition. So I think for the member to suggest that there aren't statistics kept on who comes in and how many times they come back, is the member suggesting that we shouldn't have these overdose prevention sites or safe consumption sites unless those are the criteria? I would hope not, Honourable Speaker, because lives are being saved. And very, very importantly, for many people living with opioid addiction, it is their first point of contact from which they can then get help. They build a relationship. They build some trust. I've visited these sites. I've been there when overdoses have occurred. I've seen the interactions between the staff and the volunteers and the people who come to the sites. They often know people by names. The name is often a handle that someone is using, but they get to know them. They build some trust. Sometimes it's about food, as I said. Sometimes it's about wound care. Some of these sites are embedded in broader sites that provide a wider range of services. But through visiting these overdose prevention sites, the staff are in a position to refer people for treatment. And if they were not able to go to those overdose prevention sites, start to build those relationships, then that journey that would take them on a pathway to hope might never occur.
Member from North Vancouver, Seymour.
Thank you, Chair. So then, can the minister then confirm that the ministry has no information about the repeat overdose repetitions in these overdose consumption sites?
Minister.
Our ministry does not have those records.
Member.
Thank you very much, Chair. So I guess that begs another question then. How does the ministry know that it's not the same person as part of that 800,000, 800,000 people? How does she know whether or not that could be the same person? It's not necessarily 800,000 different people. It could be the same person. So how do we actually get a handle on the numbers?
Minister of Mental Health
Chair.
and Addictions.
Thank you, Chair. I didn't say it was 800,000 people. The member's misquoting me. I said 800,000 visits. So how many discrete individuals that is, you're right, as a ministry, we do not know that. The only way to know that would be if at these overdose prevention sites and safe consumption sites, we insisted on taking down people's identifying information. And as I've said from the beginning, these pioneering and groundbreaking overdose prevention sites and safe consumption sites, which began under the previous government, there has never been a requirement to collect that information. If the member is suggesting we should do otherwise, I'd be happy to hear her suggestion. I'd also be happy to hear from her how it is she believes that would not create a barrier to people visiting those sites.
Member.
Thank you, Chair. So does the ministry have any record of how many people actually seek treatment? Not necessarily identifying who that person is, but does the ministry have any record of how many people seek treatment when they have visited an overdose prevention site?
Minister.
Thank you, Chair. I can repeat for the member, if she would like, the increased number of people who are on treatment. That we do have figures for provincially. We have an increase of 164% of new people on opioid substitution therapy. That's of new patients, an increase of 164% between June the 1st, 2017 and February 28th, 2018. And as I already mentioned, we have an 80% increase in the number of providers, healthcare professionals, doctors, and now nurse practitioners who are prescribing opioid substitution therapy. They may have their pathway to getting on treatment may or may not have been through an overdose prevention site or a safe consumption site. There are many pathways through which they could get there.
Member.
So the number of people on, so the definition, I just want to get this straight. The definition of treatment then is people on opioid substitution therapy. I'll just get that clarified.
Minister.
Thank you, Chair. The member didn't ask for a broad definition of treatment. If she would like me to find a broad definition of treatment, we can look that up for her. What I was answering very specifically, because we're talking about people who are living with opioid addiction, and the guideline developed in British Columbia by the BC Centre for Substance Use, which has now been adopted as a Canada-wide guideline, does speak to opioid substitution therapy as the first line of recommended treatment.
Member.
Thank you, Mr. Chair. So is there any other treatment out of the overdose prevention sites besides the substitution treatment that is offered to individuals that visit these sites?
Minister.
Thank you, Chair. So let me just reiterate at the outset, the purpose of these sites that we're talking about is to prevent overdoses. Overdose prevention sites and safe consumption sites are not, by definition, treatment centers. Their goal is to prevent overdose and to connect people to services that are available to them. And I also want to be very clear. I think the member may have, I don't know if the member misunderstood or not. I did not say that opioid substitution therapy is offered at or through overdose prevention sites. Overdose prevention sites were set up with a very specific purpose. People were dying because the drugs they were using were poisoned. They're dying alone. This is a safe place to consume those drugs where there is drug checking and where overdoses can be reversed, and where people can be connected to supports and services, a variety of them. The relationship building and the connections that are built are very important. Everybody's pathway is different. Everybody's pathway to treatment and recovery is different, and recovery and treatment look different for different people. But having that initial connection with someone that you trust, that you're willing to have a conversation with, whose advice you're willing to seek, whose advice you might be willing to take, is a critically important first step. So at the overdose prevention sites and the safe consumption sites, people are in a position to let the clients there know about what services and what treatment is available. So to let them know about rapid access clinics that are staffed by specialists in addiction medicine and addictions care. There are peer supporters, peer support workers who work at many of these sites, and there are peer support networks that people can refer to. They can be referred to detox. They can be referred to counseling. It's really about whatever starts to create a pathway to hope for that particular client at that particular time. And it looks very different for different clients. And if we don't accept that basic fundamental, then you know, we're going to be turning back the clock and saying there's only one pathway. And you know what? More people will die, not less people, because every person's pathway out of addiction is different. And the spectrum of treatment that's available needs to be a wide spectrum of treatment. It is the case, however, and we have, as I mentioned, in British Columbia, the BC Centre for Substance Use, which is a leading institution, not just in this country, but is recognized worldwide for its expertise. In the context of a poison drug supply, it is the case that the guidelines from the BCCSU do refer to opioid agonist treatment, opioid substitution therapy, as the first line of treatment for opioid addiction.
Member North Vancouver Seymour.
Thank you, Chair. What is the cost per visit at the overdose prevention sites?
Minister.
Thank you, Honourable Chair. So I think it's important to clarify, first of all, that safe consumption sites and overdose prevention sites were set up under the previous government. They were set up under a ministerial order that came about as a result of the public health emergency, referring to these as medically necessary health services. So health authorities at that time, and I'm talking about under the previous government, were directed to use their existing resources in order to support the creation of safe consumption sites and overdose prevention sites. And I think it's fair to say that the funding for these was somewhat opaque. And it took some time to determine exactly how these services were being funded, but the reality is that they were largely being funded out of existing resources of health authorities. When we came into office in July and presented our budget update in September 2017, we recognized the necessity of having some direct funding for overdose prevention sites and safe consumption sites. And health authorities were developing a considerable shortfall and considerable cost pressures when they were being expected to establish overdose prevention sites and safe consumption sites as mandated under the public health emergency, and to do it within existing resources. So in our budget update in September of 2017, we invested a total of $322 million over 3 years in the creation of the ministry, but largely in response to the overdose crisis. Of that money, approximately $30 million was allocated over 3 years. It's important to emphasize that that money was used and is being used to help to pay for existing safe consumption sites and overdose prevention sites, ones that existed under the previous government but were not being funded, that those resources are being used to create new overdose prevention sites and safe consumption sites, to expand the hours of those sites, and to expand the services that are available on those sites. And I've referred to the fact that for some of these overdose prevention sites and safe consumption sites, they are embedded in locations where other services are provided. So the money that I'm talking about, the approximately $30 million over 3 years, are resources that are being used to cover not just the sites, but the multitude of services that may be provided at those sites.
Member.
Thank you, Chair. So thank you. That was very good information. So I just wanted to clarify what I heard, because maybe I missed it. But I believe the minister said $30 million over 3 years to fund existing overdose prevention sites or safe consumption sites. But is there any new sites?
Minister.
What I said, Honourable Chair, was that this money is being used to help to pay for existing sites, to create new sites, to expand the hours at sites, and to expand services on those sites. Those are the 4 things that I referred to.
Thank you. To date, then,
Member?
sorry, through the chair. To date, then, there has not been any new sites yet, but this part of the 30 million will be used for new sites in addition to increasing hours and services. Do I have that correct?
Minister.
Thank you, Honourable Chair. No, you don't, actually. What I said was, and I'll repeat it for the 3rd time, these resources are being used to help pay for existing sites, to create new sites, to expand the hours at sites, and to expand services at new and previously existing sites. And the resources are to pay for the sites and the services provided at those sites.
Member.
Thank you, Chair. So how many new sites have been opened since this government came in power?
Minister.
Well, thank you and welcome, Honourable Chair. I don't know if I've had the opportunity to call you Honourable Chair before. It is a pleasure to do so. So, responding to the last question from the members opposite, as the needs of the population change, as the population is changing, as needs are identified, we are being creative and innovative in how we're delivering overdose prevention services and safe consumption services. So we have created some new sites. Some sites have changed from overdose prevention sites to safe consumption sites. Some have moved from being distinct standalone sites and have become embedded in housing, for instance, housing sites, or embedded with other services. Some have now moved and have shifted and are in healthcare settings, and all of those innovations are in response to the needs there. So I don't have a list of what all of those changes have been. I can tell you, however, that in September we had 24 overdose prevention sites, and we now have 45.
Member.
Welcome, Chair. Thank you. The minister said that there were referrals to treatment from these sites. I think it was the overdose prevention sites. Does the ministry have numbers on the amount of referrals, and if so, broken down by site?
Minister.
Thank you, Honourable Chair. As I stated in response to the last question, there are many, many different models of overdose prevention sites and safe consumption sites. We know that referrals are happening at these sites. We know that health authorities are working to track those referrals where they are responsible for the sites, but many of them actually don't come under the health authorities. We also know, and as I've explained this to the member, I think 2 or 3 times now, that identifying information is not required. Therefore, the ability to track the referral to treatment and the follow-through on the referral to treatment is not possible. But even if there's no referral to treatment for addiction, people may well be referred to, and in fact they are, referred to a variety of other support services. That could be supportive housing, that can be counseling, that can be healthcare, very often a health intervention. And that can in turn lead to people being referred to treatment. So if the member has a specific site in a specific health authority that she would like us to try and get information on, we will certainly endeavor to get that.
Member.
Thank you, Chair. Yeah, I'm just trying to get an idea of when people do use these sites. is there any record of, she's confirmed that there is no general record of obviously individuals, but that people are actually getting the opportunity to get to treatment? Like, is there any way of following these people, or is there any way of recording the success of treatment by these people accessing these facilities? So it's the first line of defense. You've got somebody there that is there available to help. But do we have any record that this in fact is happening and that people are actually benefiting from treatment services because of these sites?
Minister?
Thank you, Honourable Chair. I've already indicated, I believe, a few times that we're not in a position to measure this at an individual level. We are in a position to measure at a population level. And let me repeat these stats. We have seen an 80% increase in the number of providers who are prescribing opioid substitution therapy between June 1st, 2017 and February 28th, 2018. And we have seen a 164% increase of new people on opioid substitution therapy. We also have had 800,000 visits to the sites that we've been talking about, and we've had 5,300 overdoses reversed. And I have already explained to the member a few times that people can access, are able to be provided referrals to treatment and referral to other kinds of support services when they visit these sites, understanding that the sites vary widely. Some health authorities are able to measure the referrals from a particular site. They're not able to measure it according to individuals, but some health authorities, as I indicated earlier, are able to provide some measurement of the referrals. And if the member, I repeat, that if the member would like information about particular sites, particular health authorities, we're happy to provide that to her.
Member?
Yes, thank you, Chair. So there seems to be a growth. The minister confirmed that 80% increase in providers, 164% of new people, 800,000 visits. And what I'm asking is if there is no way of tracking them, how are we keeping track on the costs? And how are we evaluating the services that we're providing if we don't have any record of the actual results of where these people have ended up? In other words, to referrals or getting well.
Minister?
Thank you, Honourable Chair. I think it's important to go back to what the purpose is of overdose prevention sites and supervised consumption sites. And this isn't something we invented. This is something that was in place under the previous government. Overdose prevention and supervised consumption services provide people who use drugs with a space to consume their drugs under the supervision of someone trained to administer naloxone and provide other emergency first aid services in the event of an overdose. That's why safe consumption sites and overdose prevention sites were established. And they are doing an amazing job fulfilling this mandate, which is a safe place for people to consume their drugs and have someone there who can administer naloxone and provide other emergency first aid services in the event of an overdose. The figures, I think, speak for themselves. 800,000 visits. 800,000 visits. 5,300 overdoses reversed. Not a single life lost. Now, it is absolutely the case that we want to, as a government, that we absolutely want to connect people to treatment and recovery programs as soon as possible. And certainly, when I've talked to people on the front lines, whether that's first responders or whether it's people who are working in these sites, it's people working in healthcare, in community agencies, you name it. They all say one of our biggest challenges is we need to have treatment on demand. And the member will have heard the police chief of Vancouver use those words. She will have heard many other people say, sadly, we don't have a system where people are able to get treatment on demand. So I would say that we are working overtime, and the people who are working in these sites, as well as people who are working in addiction services, in mental health services, in various healthcare settings, are all doing their best within the context of a system for treatment and recovery that is far from adequate in the province of British Columbia. We plan to improve that. We are working hard on a mental health and addiction strategy to improve access to mental health and addiction services across the entire spectrum of addiction services. We're not going to get there overnight, but we are connecting more people to treatment and recovery, not just through the overdose prevention sites and the safe consumption sites, but through a variety of programs and services in the healthcare system and elsewhere, a significant increase in the number of people who are being connected to treatment. And Honourable Speaker, do we have, Honourable Chair, do we have a ways to go? Absolutely we do. We have a lot of work to do to overcome many years of neglect of the addiction care system in the province of British Columbia.
Member?
Thank you, Chair. There's that word again, neglect. But the minister has made it really clear for the last hour or so that the model that they're using is a model that was already present when we were in government. But anyways, I go on. I'd like to get a different little track here. So the minister had said that the opioid substitution therapy was the first treatment as specified by, and I believe she said, the BC Centre for Substance Use. Are there any treatment options that are available from this government that are not including opioid substitution therapy?
Minister?
Thank you, Honourable Chair. What I said about opioid substitution therapy was not that it was the only option. What I said was, according to evidence and research by the BC Centre for Substance Use, that opioid substitution treatment, in medical terms, referred to as opioid agonist therapy, is the first line of evidence-based treatment for opioid addiction. I'm not a clinical expert, neither is the member opposite, but we, I think, are both strong admirers of the work of the BC Centre for Substance Use, whose work is recognized not just across the country, but around the world. We firmly believe that there need to be a wide array of treatment options available for British Columbians, whether they are suffering from opioid addiction, alcohol addiction, addiction to other substances. And our goal is to ensure that, in fact, that wide range of treatment options is in place. That can include detox. We think it's critically important that we also address issues like supportive housing, and I'm certainly very proud of the work that our government has done, the Minister of Municipal Affairs and Housing, in the action plan to address homelessness. As we know, the overwhelming majority of people who are homeless in British Columbia are also living with mental illness and addiction. And so in the majority of these projects that have been built or are being planned for people who are homeless, we'll have support services, including services dealing with mental health and addictions. It's critically important that that wide range of treatment options include access to counseling, because as we know, people who are living with addictions are also often dealing with mental health issues, with trauma, with unresolved trauma. And one of the very, very important options and pathways to hope that our government is working on, I referred to at the outset, is the work that we're doing with the First Nations Health Authority. which is, as I mentioned earlier, very much about reconciliation and action. And it's very much about a partnership and really learning from and working in collaboration with the First Nations Health Authority, with Métis Nation, with Association of Aboriginal Friendship Centres. And we have, some of that work has already begun. We have now, through the First Nations Health Authority, there will, some are already underway, some will be established in the coming weeks and the months, 55 projects in First Nations communities across British Columbia that are about overdose prevention, that are about Indigenous healing. Many of them are land-based, they're community-driven, they're nation-based, and they are very much the direction that that Indigenous people in British Columbia want to see us taking, and that's a really critical part of our the work that we're doing now to save lives, to prevent overdose, and to provide a variety of different pathways to hope and to healing for Indigenous people and for all British Columbians.
Member?
Thank you, Chair. I have a question about the coroner's report, and I've got the one that is January 1st, 2008 to February 28th, 2018. That's the most recent one I have. They state in 2018, 91% of the illicit drug overdose deaths occurred inside, 63% private residence, 28% other inside locations, and 8% occurred outside in vehicles, sidewalks, streets, parks, etc. Does the ministry have any record of any of those outside deaths being outside overdose prevention sites?
Minister?
Thank you. We are not aware that any of those deaths occurred outside overdose prevention sites.
Member?
Thank you very much. With the 91% of illicit drug overdose deaths that occurred inside, does the minister know or has the ministry any information on any of those people that would or could have used the overdose consumption sites wherever they are? So I guess maybe that wasn't too clear. I guess I'll turn it around the other way. If there's 91% of the people that are dying of overdoses, and we've got these overdose consumption sites, those 91% are not using those sites. So what is in store to help those people, the 91%?
Minister?
Thank you, Honourable Chair. I think it's helpful to go back perhaps to the beginning of when the public health emergency was declared, because, and the provincial health officer, Bonnie Henry, is with us here today, and she has reminded me that when the public health emergency was declared, approximately, and we could look up the exact number, but approximately 60% of people who were dying inside. That number has now gone up dramatically. A lot of the people who were dying, many of the people who were dying at that time were dying on the streets. They were dying in areas where there are significant concentrations of people who are using drugs. And it is certainly safe to say that the creation of overdose prevention sites and safe consumption sites has saved a lot of lives of people who were previously dying on the streets, because there has been provided sites where people can use drugs safely, and where there are people who can administer naloxone and life-saving measures. So we're now seeing a shift, and we're now seeing 91% of people who are dying inside, whether that's in their own homes or whether it's inside someone else's home. That's a significant shift. And we know from the coroner's report, we know from the work that a lot of people are doing, that very, very often, after someone dies of an overdose, family and friends will say, "We had no idea. We had no idea." We know people are dying from all walks of life in all corners of the province. And that's exactly why we need to, we've undertaken a couple of things. We need to bring drug use, opioid addiction, out of the shadows. We have to break down the walls of silence around drug use so that people are willing to have those courageous conversations with their families and their friends and their loved ones and their coworkers, and so that people who are living with drug addiction are willing to reach out for help, both to share what they're living with right now, the addiction they're living with, as well as to seek help. We know that stigma is a barrier to seeking help. That means stigma kills. So it's critically important that we overcome stigma. And we have made that an important priority in our ministry. And people in all corners of this province have welcomed the anti-stigma campaign that we've launched. And we've just begun. The member will have seen, as have people from all corners of BC, the anti-stigma campaign, the TV ads, the radio, the work that was done with the Vancouver Canucks, the bus shelter ads, the transit ads. Those images are everywhere. And those images say, father, brother, coworker, hockey player. People who use drugs are real people. Get informed, get involved, get help. Go to stopoverdosebc.ca. We need to reach people who are using drugs alone to break down the walls of silence, and we need to reach the people who care for them to break down the walls of silence so that we can ensure that those people get connected to treatment and to a pathway to recovery and hope. Because they are using alone because of shame. They're using alone because of stigma. So our message has been very loud and clear on this score. Addiction is not a moral failure. Addiction is a health issue, and we need to treat it that way. So our anti-stigma campaign is absolutely central to trying to reach people who are using alone and to reach the people who surround them. The other critical piece in this is, and you will have heard the Minister of Health speaking about this, you will have heard our government's commitment to this. We're moving forward very aggressively to establish primary care teams in communities across the province, and access to mental health and substance use services will be an integral part of those teams. And that's really important because we need to take down the barriers, we need to reduce the stigma of people seeking help for mental illness and for addictions, and one of the ways to do that is to ensure that these services are integrated with primary care, and that's exactly what we plan to do going forward.
Member?
Thank you, Chair. So if the results of people using alone has gone up since the public health emergency was announced, would then, getting back to my original question, a reduction in the number of people dying alone be a potential performance measure for the evaluation, say, of anti-stigma campaigns or other campaigns that the government is instigating?
Minister?
Thank you, Honourable Chair. I want to be clear that what I said was that the proportion of people who are dying alone has gone up. So the member was clear about that. Obviously, we want all the numbers to come down. We want the numbers of people who are dying alone to come down. We want the numbers of people who are dying on the street to come down. We want the numbers of people who are dying to come down. Of course we do. There is not one single solution. There is not one simple solution that is going to ensure that that happens, especially in the context of a poisoned drug supply, a toxic drug supply. I have the opportunity to meet with a wide variety of people involved in the overdose response, including a meeting just a few weeks ago at the Justice Institute, organized by the Overdose Emergency Response Center. This was firefighters, police, an ambulance. And the member probably knows this, but I think it's important to understand what it is we're dealing with here with this toxic drug supply, because we're talking about minuscule granules that are smuggled into the country, that are mixed with other substances, with very small ratio of this fentanyl or carfentanil mixed with other substances, and the supply, sometimes a really bad batch hits the streets. The numbers of people who are dying seem to level off for a few months through all kinds of heroic efforts. And then they go back up, they come back down. It has everything to do with the toxic drugs that are on the street and the supply of them that are still coming into the country and that are still appearing on the street despite everybody's best efforts. So we're tackling it on a lot of different fronts at once, and I've talked about that already. Overdose prevention sites and safe consumption sites are part of the picture. Primary care teams that also are robust in the area of mental health and substance use services are part of it. Housing the homeless and providing support services, because there is nothing more desperate or hopeless than not having a roof over your head. And if we save someone's life with naloxone in an overdose prevention site, or if a first responder saves their lives and they go back to living on the street, as too many people are doing now, they go back to a life of despair and hopelessness. Therefore, tackling homelessness with support services for mental health and substance use is an important part of the solution. And I'm very proud of the efforts that our government is taking on that front. But I think it's important that we not lose track of the incredibly heroic work that is happening out there that is saving lives. Whether we've talked about the overdose prevention sites and safe consumption sites and how many overdoses have been reversed there. But if we take the time to talk to some of the first responders, they will tell you that in one case that I was told about, for 21 lives that were saved, one life was lost. It's tragic that that one life was lost, but they also saved 21 lives. There are other parts of the city, other parts of the province, where the ratios are different. It depends on the array of services, frankly, that are available in that community. But thousands of lives are being saved, and I want to take the opportunity to pay tribute to the amazing people who are on the front lines, who go unrecognized, but who are already making an enormous difference in this overdose crisis.
Member?
Thank you, Chair, and certainly all of us are very appreciative of the first responders, and also they themselves can suffer from PTSD and other things. So that's a question for another time. I'm going to just change the track a little bit, just as we're moving along. I wanted to talk about the federal announcement, the money that the federal government had provided, and I know that there was there's a partnership going on with regards to the pilot. And I'm wondering, I think that was $150 million to go to the opioid crisis. Does the minister know how much of that is going to British Columbia? And does the minister have any suggestions as to how that money will be used?
Minister.
Thank you, Honourable Chair. Just before I get to answering the question, I do want to comment on the issue that the member raised about PTSD for first responders, because certainly we have heard now for the last several years, even before the public health emergency was declared, we've heard from ambulance, paramedics, fire, and police about the trauma that they experience on the job, and the severe impact that it has on their psychological well-being, sometimes resulting in PTSD. So one of the things that we're very proud that we've done, and I certainly congratulate the Minister of Labour for having introduced amendments, introduced legislation that would create a presumptive disability claim for first responders for mental disorder, including PTSD, but not exclusively PTSD. And this is something that they have certainly been pressing for a number of years. Initially, my colleague, who was then the Labour critic, now the Minister for Social Development and Poverty Reduction, had introduced a private member's bill that dealt with presumptive disability claims in the area of PTSD. But based on further consultation with first responders, they indicated that they thought it was really important that the supports are there for people who experience trauma at work before you get to the point of PTSD, and that it was important to put programs and supports in place through WorkSafe BC prior to it reaching such an acute stage. And so the language that has been introduced, the legislation that has been introduced, in fact deals with mental disorder, including PTSD, but not limited to PTSD. On the federal funding, the federal government has announced $150 million in 1 year, in one-time only funding to respond to the overdose crisis. That money is targeted towards treatment and improving access to care. And we have the provinces have commenced negotiations with the federal government on what their allocation will be.
Member?
So the answer to the question is that nothing is determined at this point then. Is that correct?
Minister?
The answer to the question is that $150 million has been allocated by the federal government in one-time funding. It will be targeted to treatment and improving access to treatment, and we have commenced negotiations on how that money will be allocated to British Columbia.
Member?
Could the minister expand on that a little bit? How much of that would be available to treatment or recovery services?
Minister?
Thank you, Chair. So the entire $150 million by the federal government, they have indicated that is to be targeted to treatment and improving access to treatment. The specifics for British Columbia will be determined when we know what our allocation is.
Member?
Okay, thank you very much, Chair. I'd like to talk about the pilot project. I've got some information here from Dr. Mark Tyndall, the Executive Director of the BC Centre for Disease Control. Said the idea is that people at high risk of overdose, once registered, will be able to pick up hydromorphine pills at either supportive housing units or supervised drug use facilities 2 or 3 times a day and self-administer them. And I think it is started. This pilot project is just started. I'm wondering if the minister has any details on the plans, the cost, and how many people are going to be served by this program.
Minister?
Thank you, Honourable Chair. I want to be clear, this is not a program. This is a research project that is funded by the federal government. Our government supports testing innovative projects that aim to save lives in the middle of the overdose crisis, and a recent study has shown that hydromorphone is an effective option for opioid substitution therapy. As the member knows, our street drug supply is toxic, and a safer supply of prescription medication will help people to who use opioids to avoid overdose and death. This pilot, this research project, funded by the federal government, will provide a controlled dosage of hydromorphone pills to people who are at risk of an overdose and who meet specified eligibility criteria. All participants will be assessed by a physician. The pilot will test settings and models for both safety and efficacy. The pilot will be in settings that provide supportive services, so people accessing the program will have the opportunity to connect to other care. This may include harm reduction, connection to treatment options, and other healthcare and social supports. Health Canada has a program called the Substance Use and Addictions Program, SUAP, and it awarded the BC Centre for Disease Control $1.47 million over 3 years to complete this research project. The BC Centre for Disease Control is currently in the project development stage, and the research project is expected to begin in July.
Thank you, Chair. Does the minister have any estimates about how many people that will serve and the cost, and if there is a limit?
Minister?
Thank you, Honourable Chair. There is no plan for how many people this program will serve. It is a research project. I want to really underline that. It's a research project. It will test settings and models for both safety and efficacy of providing a controlled dosage of hydromorphone pills, which is, as the member knows, hydromorphone is a legal drug that is now used for management of pain post-surgery and so on. People will need to meet specified eligibility requirements, but again, this is a research project. The funding comes from Health Canada, which awarded $1.47 million over 3 years under their substance use and addiction program awarded to the BC Centre for Disease Control. And the purpose of it is to evaluate it in order to see whether this is an effective way to proceed.
Member?
When the people are coming in there, would there be any opportunity or any options for other forms of treatment, like, say, recovery options or any other treatment besides the substitution therapies?
Minister?
When the member refers to coming in there, what is she referring to? Coming in there?
I'm just trying to get an idea of
Member?
Sorry, through the chair. I'm just trying to get an idea of who this project, research project, is serving, and whether or not there's any other options for those people to get any other treatment.
Minister?
Thank you, Chair. I want to clarify, this is not a treatment program. The member is speaking of it as if it were a treatment program. It is a research project. The parameters and the scope of the project will be determined by the BC Centre for Substance Use using federal government funding.
Member?
Thank you very much, Chair. Okay, I'll change a little bit of tack.
Minister?
Mistake, Honourable Chair. I said BC Centre for Substance Use. I should have said BC Centre for Disease Control.
Member?
Hi, thank you very much, Chair. So I'm going to change tack just a little bit now. The minister announced in the last budget $322 million in her budget. I'm just wondering how much of that is going to go to recovery or addiction facilities.
Minister?
Thank you, Honourable Speaker. Well, you know, the money that committed in September really covers a wide range of programs and services and treatment. We've already spoken about the opioid agonist treatment, which is a significant investment, but we also included in the September budget update multidisciplinary pain management program, outreach teams to help people to navigate the system and to help people to get the support and the services that they need, including the counseling and addiction services and referrals to treatment. I've described in some detail already, but I'm happy to talk about it further. We're very proud of it, the work that we're doing in partnership with the First Nations Health Authority, which is really about Indigenous land-based healings that really use traditional healing and connection to land and family and culture as an integral part of those treatment and recovery programs. That was $20 million over 3 years. I've referred to the outreach teams already. the Foundry programs, I mean, you know, that the member's very familiar with and very supportive of, which are very much about early intervention and prevention, but they're also about referrals of people to treatment and helping people to get on that pathway to recovery. And I hope that the member noticed just a few weeks ago, speaking of treatment and recovery, that we have just a few weeks ago announced a new treatment facility for youth that will be built in Chilliwack, 40 beds for youth. Really an innovative program, one that will very much involve the youth and family members in their own treatment and recovery plans. One that is also very innovative in that it involves a lot of sports and physical activities. It involves people in employment counseling, and it's really about helping to ensure that when the young people leave that treatment and recovery facility, that they are prepared to really embark on a better pathway in their lives. So it's really a variety of different programs, and some of them involve prevention, some of them involve harm reduction, some of them involve treatment and recovery, but they don't all have strict lines between them, Honourable Chair, because it's not a straight line often from someone living with an addiction to getting to their pathway to hope. So we're supporting people in many different ways with the $322 million that we allocated in September, but also with the considerable resources that we allocated in Budget 2018, which has a very significant focus on upstream investments. And upstream investments are very much about prevention, ranging from investing in childcare, which will make a huge difference to vulnerable kids, to children at risk, to investing resources in youth aging out of care who are at great risk of mental illness and of developing addictions. And I've already spoken about homelessness and putting roofs over people's head together with treatment and together with support services and together with mental health and addiction services.
Members of this House will recess for 5 minutes.
5 minutes.
Members, I call this committee back to order and recognize the minister.
In my enthusiasm about the announcement that we made recently about the Chilliwack Youth Treatment Facility, I said that there were 40 beds when in fact there are 20. So it's still innovative and very exciting, and it's going to do a whole lot of great things, but it's 20 beds, not 40, so I just wanted to correct the record on that.
Member?
Yes, thank you, Chair. So I'd just like to go along the route of residential treatment and recovery. And I'm wondering if I could get something more specific about the money that has been devoted out of this budget that will be directed to either residential treatment or recovery options in residential areas.
Minister.
Honourable Chair, I don't think I've called you that before either. Thank you. I certainly appreciate the member's question. I think it's really important to remember that, as we've discussed earlier, that treatment and recovery and the pathway to treatment and recovery looks very different for different individuals, and that means that we have to ensure that we have in place or put in place in the future a wide range of treatment options and services depending on people's needs. It's not a one-size-fits-all solution. We need to ensure that people have access to the most appropriate treatment for their specific circumstances when they need it. And residential treatment beds are certainly one component of a broad continuum of care, but they are generally reserved for people who require a high intensity of services and supports to address what are severe, complex substance use problems in what is a structured, safe, and stable living environment. But treatment and recovery services can also be offered in various settings, including in a person's home, in their community, staffed residential care, hospital care, specialized inpatient care, virtual care facilities. or in one of the many programs that are now being initiated in partnership with the First Nations Health Authority, treatment programs in 55 First Nations across the province. Since this government has taken office, currently 34 beds and 40 outpatient spaces have been implemented, and work is underway to implement another 26 beds and 10 outpatient spaces over the coming months, and the total outpatient spaces will support approximately 200 people annually.
Member?
Thank you, Chair. So I think the minister said 34 beds now with another 26 beds coming. Can the minister tell us where they are? Already facilities that are already there? Is this new facilities?
Minister.
Honourable Chair. So to respond to the member's question, the information that I gave you just a minute ago was about beds and treatment spaces. This could be an expansion of existing facilities, or these beds could be in new facilities. I don't have the breakdown here today, the specific information about which beds have been implemented where, and which ones are in new or existing facilities. If the member wants more information about where they're being implemented, I would be happy to provide that to her, which health authorities and which locations.
Member.
Yes, thank you, Chair. I would appreciate that information. So are any of those designated beds in private facilities?
Minister.
Thank you. The answer is yes. Some of them are. The government is currently evaluating a mixed model of care, including both private and nonprofit residential treatment beds. And after a procurement process last year, Provincial Health Services Authority contracted with private operators to provide 10 private beds at the Cedars private facility on the island and 20 with the Phoenix Society in Surrey to ensure the best outcomes and the most effective use of public funds. The model is being evaluated while the services are being delivered, and depending on the outcome, the province will decide whether to continue the mix of private and nonprofit beds.
Member.
Thank you, Chair. Are those beds that are covered publicly in private facilities specified what kind of treatment options they have to do to get public funding?
Minister.
Thank you, Honourable Chair. Well, the framework for any of the funding that is allocated to treatment facilities, they are required to operate under the clinical best practice guidelines. But every individual's treatment plan can be different, and each individual's treatment plan is developed in accordance with in collaboration between the patient and their clinician. So the range of options available at these facilities can range from abstinence to people being on opioid agonist therapy like Suboxone, for instance. The evaluation that will be conducted will look at the results of this.
Member.
Thank you, Chair. So are abstinence-based treatment options part of the publicly funded recovery-orientated addiction services?
Minister.
Honourable Chair, I think I've just said that this is a project that is currently underway, where government is evaluating this mixed model of care that encompasses private and nonprofit residential, and it includes 10 private beds at Cedars on the island, 20 with Phoenix, and they deliver a range of options, and the treatment plan is developed in collaboration between the patient and the clinician, and that could be abstinence-based and still receive funding, or it could be someone who is on Suboxone, for instance, or other opioid substitution therapies.
Member.
Thank you, Chair. Does somebody that is getting funded through the publicly available beds in a private facility, can they be any socio-demographic, or are those ones paid by insurance, or is the public system paying for them, or do they have to be on social assistance or whatever? I'm just trying to get an idea of the socio-demographics and the availability of those publicly funded abstinence-based beds.
Minister.
Thank you, Honourable Chair. I want to be very clear, there are no designated type of treatment beds. So it's not as if the member referred to abstinence-based treatment beds versus other kinds of beds. So under this program that I just referred to, because the member asked about funding for private beds, they aren't designated as abstinence-based or opioid substitution treatment beds. They're treatment beds. The Ministry of Health has conducted an early evaluation of these beds, and it shows that there is people from a broad range of socioeconomic backgrounds who are accessing these beds. People get these beds through referrals from health authorities, and the referrals are needs-based, not means-based. Now, having said that, in the big picture, and so there's no change in how people are referred. I want to be clear about that. In the big picture, we know we have a long way to go to ensure that we have access to treatment programs to remove financial barriers to treatment programs. That's a long-standing problem in this province that we need to tackle and that we will tackle in the future, because we do know that if you either have the personal financial means, or if you have good extended health plan or EAP plan, you may be able to get access to a broader range of treatment facilities. And we know that if you are very poor and are able to be subsidized, that you have access, but there are an awful lot of people who don't have access. So that's a big picture issue that we absolutely need to tackle in the future. But this particular program that the member was asking about, the way that people are referred, there's been no change in that from the past. But the early evaluation does show that people from a broad spectrum of socioeconomic backgrounds are utilizing these treatment facilities.
Member.
Yes, thank you, Chair. That's precisely what I had heard, that it was only if you are very poor, in other words, you have no assets, or you had the means through your healthcare plan, or were essentially wealthy enough to afford a abstinence-based treatment facility. But the missing middle, in other words, the majority of people, do not have access to those beds because they don't meet those two criterias. So my question is there going to be a concerted effort to offer more publicly funded beds in abstinence-based treatment facilities than there are now?
Minister.
Thank you, Chair. So let me just be very clear that the comments that I made about access were about the big picture for the system of mental health, well, addictions care in particular, but it could be said in the context of mental health care as well in the province, that access is a huge issue and that income level makes a difference, unfortunately. This is a system we have inherited, so I know that the member doesn't like it when I refer to 16 years of neglect, but it is a system we inherited, and there are some important challenges in it that need to be overcome, and that is certainly on our agenda for the work that we need to do in the future to build a system for mental health and addictions care where the access to care doesn't depend on the size of your pocketbook, and so on. But in the context, in the very specific context of the member's question about whether or not we are funding, as government, any private beds, in the context of these particular beds that I referred to, let me just reiterate that the Ministry of Health has conducted an early evaluation of the use of those beds, which are private and not-for-profit, and it shows that they are being utilized by people from a broad range of socioeconomic backgrounds. People are referred there from health authorities, and they get there based on needs, not based on their financial means.
Member.
And I'll just ask one more clarifying question on this topic. So those beds that are available in a private facility but funded publicly are can and are abstinent-based beds. They're not required to be, for instance, on Suboxone or any other opioid substitution therapy.
Minister.
Thank you, Chair. Well, I could say asked and answered, but instead I will repeat my answer. There are no designated type of treatment beds. You don't have to be, some people can be on a program of abstinence. People can be on opioid substitution therapy, like Suboxone. These are not designated beds for a particular pathway to treatment and recovery, because we understand that recovery looks different for different people. Let me just pull out, I know that we canvassed this in estimates in September. And this is a definition from the Canadian Centre on Substance Use, a definition of recovery. They say, quote, "Recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential." So that's a really important starting place, because it recognizes there are many pathways to hope. There are many pathways to recovery. Treatment options vary. They need to be tailored according to individual needs, and recovery looks different for different people. So, as I stated before and will repeat, the treatment plan is determined through collaboration between the patient and the clinical service provider. And that could be abstinence, or it could be a treatment plan like Suboxone, and it could be eventually not being on Suboxone, or it could be on longer range. That's not up to the Ministry of Mental Health and Addictions to determine. That's up to the patient and their care provider to determine.
Member.
Thank you for that clarification. So I've got a youth in early to mid-20s that has addiction problems, and I want them to get into a recovery facility that offers abstinence-based treatment. I don't want them to go on Suboxone. Do I have the availability to do that? I'm in the middle range. I'm not too poor, and I don't have $30,000 at my disposal right now, or even $20,000. Am I able to get in a waiting list? And if it is a waiting list, how long is that going to take me? But am I allowed to get public funding if I meet that criteria for my youth?
Minister.
Thank you, Chair. I'm a little bit confused when the member opposite says, "I have a 22-year-old, I have a patient." So I don't know if she's referring to I as a parent, I as an MLA, what the I is. But what I can say is that a 22-year-old young person would, their pathway, their treatment plan would be determined based on what's clinically best for that patient, would be determined between the patient and the clinician.
Member.
Thank you, Chair. So there was an announcement that went out recently, and I think there was anyways, I'll just read it out because I'm going to, I'll read it out in context and then I'll ask you the question. By September 2019, the Ministry of Health and Ministry of Mental Health and Addictions, in collaborations with First Nations Health Authority, will develop and revise provincial regulations for public and private addiction treatment facilities and services to set standards for, and I quote, provision of evidence-based treatment, and require that these programs be systematically evaluated and monitored to ensure compliance. I'm sure this is kind of what the minister was talking about, but my question is specific about the statement of evidence-based treatment. Can the minister describe what evidence-based treatment is?
Minister.
Thank you, Chair. I'd like to clarify, because the line of questioning, I think the discussions that we've had in the last several hours have been pretty much focused on opioid addiction. So I do want to clarify that the member's question relates to opioid treatment for opioid addiction. And if that is in fact the case, then when we talk about the evidence-based guidelines for opioid treatment, opioid addiction treatment, opioid use disorder, we're talking about the guidelines that have been developed by the BC Centre for Substance Use, guidelines which have also been adopted nationally.
Member.
So getting back to the question about evidence-based, so that, again, I just want to make sure, because I get asked these questions by people that are talking to me, that would include abstinence-based recovery treatment.
Minister.
Thank you, Chair. I asked for a clarification, and I wonder if the member is in a position to respond so that we're talking about the same thing. Did the member hear my question? Would she like me to repeat it? Your question? Yes. Sure. Okay. What I said was that I'm assuming, because of the line of questioning we've had so far, that what we were discussing was treatment for opioid use disorder, opioid addiction. And if that is in fact the case, which I'd like the member to clarify, then her question was about evidence-based treatment guidelines. And what I can affirm is that these evidence-based treatment guidelines for opioid use disorder, that the ones that are followed are developed by the BC Centre for Substance Use, and they have been adopted nationally for opioid use disorder.
Thank you, Minister. Member.
Yes, sorry, I was nodding my head when she was asking me the question, so I apologize for the lack of communication there. All right, we'll carry on. I have another question about treatment models. I know that the minister has spent some time talking to the folks from Portugal. She was present at a conference, and I think went to great lengths to go and take Dr. Gallo on a tour. I think this was last year. And I'm wondering whether or not the minister has thought about adopting the Portuguese model with regards to really encouraging people to go into treatment facilities that include abstinence-based treatment.
Minister.
Thank you, Honourable Chair. I was indeed present at a recovery conference in New Westminster just a few weeks after I was appointed to this position, and was asked to give a keynote speech, and had the opportunity also to hear from the head of the Drug Directorate of Portugal, and to spend some time with him afterwards learning more about the Portuguese model. And it's interesting, Honourable Chair, that people take a lot of different things from the Portuguese model, and that's because, in fact, the Portuguese model is not just one simple thing. They have indeed decriminalized possession of small amounts of drugs for personal possession. But the defining feature of the Portuguese model is actually not that. The defining model of it is a number of different things. The defining features, several different defining features, I would say. First of all, they have treatment on demand. So people are, instead of being arrested if they have small amounts of drugs for personal use, they are diverted to a dissuasion panel. And they are offered treatment on demand, and they literally mean that. Here's an appointment for you tomorrow. That treatment includes a wide range of options. It includes abstinence, it includes opioid substitution therapy, it includes a wide range of treatment options. But also, Honorable Chair, one of the most significant things, and one that I actually don't hear the member opposite talking about very much, is the kinds of social supports that are offered in Portugal, because they fully appreciate what our government appreciates, which is that we need to be supporting the whole person, that a person living with an addiction, in order for them to have a pathway to hope, we need to deal with them as a whole person. And that means in Portugal, for instance, they have people who offer social supports. They have people who work with people to find adequate housing if that's what they need. And very importantly, they have access to, yes, addiction treatment, yes, counseling, yes, housing supports, but also employment options. And the head of the Drug Directorate spent some time actually talking to me about the amount of time that he and his team literally spent going door to door in Lisbon and other communities, approaching employers who were willing to offer employment to people who were in treatment. A wide variety of treatments, but on a pathway to recovery, but with various different options. And he talked about how absolutely critical that housing support, the employment support, the other social supports, the counseling were to go hand in hand with treatment on demand. Our government takes that kind of approach very, very seriously, and it was one of the things that the head of the Drug Directorate really appreciated in the approach that I explained on behalf of our government in the keynote speech that I gave there, that was the approach that we were taking to mental health and addictions, and that was the approach that we were taking to our work in general, an all-of-government approach to tackling these problems, whether it's housing and homelessness or whether it's mental health and addictions. And that's also very much the approach that we're taking through our Overdose Emergency Response Center, where the partners that we bring together, we have our specialized team at the center, who really are the ones that are working with local teams to identify the gaps and where we need to take action. But those community action teams bring together a wide spectrum of service providers, from housing to mental health and addictions, to first responders, to community agencies, because we absolutely know that if we're going to provide pathways to hope, we need to provide a wide range of supports for people.
Member.
Thank you very much, Chair. Yes, I'm very familiar with the Portuguese model, and that's why I asked the question. I am wondering whether or not this government, and I asked previously about the number of beds that are available to people in recovery facilities, that if they're, and it seems like the Minister is supportive of the Portuguese model, will there be a plan then to have people that, for instance, show up at a overdose an overdose facility, overdose prevention facility, to actually access and have a system like this dissuasion, to have the system to be able to get them into treatment right away, as opposed to just letting them go, and then sometimes they end up coming back. And that's exactly what I was getting at. So is there a plan to perhaps offer these dissuasion type programs to facilities like overdose prevention sites?
Minister.
Thank you, Honourable Chair. Well, certainly, we're, as a government and as a ministry, we're going to be looking at a wide variety of models. The Portuguese model is a very interesting one. There are other there are other models in Europe, and frankly, there are some interesting models in the United States. And there's a lot of innovative work already being done in this country. There's a lot of innovative work being done already, especially in this province. When I referred to a meeting I had recently organized under the auspices of the Overdose Emergency Response Center that brought together first responders and The police, there were Deputy Police Chief from Abbotsford, for instance, was there, and he was explaining to his colleagues and to us some of the models that exist in the United States that he thinks are important to look at. But I think, what underpins what we're hearing from a lot of people, including police, is that we need to look at models where we provide a wider range of treatment options for people, but also, very importantly, that we provide social supports for people, that those things need to go hand in hand. And it's far too simplistic to say we pluck this from this model and that's why it's working. The reality is, if you talk to people in Portugal, it's not working for one reason, it's working for a variety of different reasons. And they totally changed their model of how they dealt with, they totally changed their approach to drug policy. But there are communities, there are police departments, there are communities that are doing some very innovative things also that we want to learn from. But looking at all of this will be part and parcel of us developing a better strategy for mental health and addictions for British Columbians, which is the mandate of our ministry and which we are working hard on and learning from every jurisdiction so that we can build a system that meets the needs of British Columbians.
Member.
Thank you, Chair. And just a little break because I've got a colleague here that has some questions and her time is limited. So I thought that I would let our colleague from Prince George Valemount ask her questions to the Minister. Thank you, Chair. Following up on that question with regards to the availability of residential care beds that are publicly funded, I did a brief check on one day in April and phoned up a bunch of facilities. These were private facilities that had beds available, but they just weren't funded. In other words, they were beds that were available if people had the means to be able to afford them, but otherwise they sit empty. So, and the number that I was told in 7 facilities, there was 125 beds that were available. So my question is, given the fact that there are 105 beds available for our recovery facilities today in private facilities, will the Minister agree to funding those from the government so that there's not empty beds and that people can access them that cannot afford the $40,000, $50,000 or they are not on welfare?
Minister.
Thank you. Well, this is an issue that we discussed earlier. And as I indicated, I don't know, a couple of hours ago, 2 or 3 hours ago perhaps, government is currently evaluating a mixed model of care, including both private and nonprofit residential treatment beds. We had a procurement process last year, and the Provincial Health Services Authority contracted with private operators to provide 10 private beds on the Cedars private facility on the island and 20 with Phoenix Society in Surrey. And as I also stated earlier, in order to ensure the best outcomes and the most effective use of public funds, this model is being evaluated, which is a responsible thing to do. It's being evaluated while the services are being delivered, and depending on the outcomes, the province will determine whether or how to continue the mix of using private and nonprofit beds.
Thank you, Minister. And noting the hour.
And noting the hour, I'm told I have to say
The
this.
script. Yes.
Okay, I move that the committee rise and report progress and ask leave to sit again.
Members have heard the question. All those in favor? Opposed? Carried. Thank you, members. This committee is now adjourned.